discussing the thrombotic microangiopathies, thrombotic thrombocytopenic purpura, and hemolytic uremic syndrome, NDIC. So you can see the hemolytic uremic syndrome. The hemolytic uremic syndrome consists of the hemolytic anemia, thrombocytopenia, and the uremia. ये जो green color नजर आ रहा है ना, that includes the hemolytic uremic syndrome. This is a triad. It includes all these three things: hemolytic anemia, uremia, and thrombocytopenia. Now this TTP, thrombotic thrombocytopenic purpura, it includes the five things: hemolytic anemia, uremia, thrombocytopenia, fever, and the neurological symptoms, signs and symptoms. So this is known as the pentad. इसमें 5 symptoms आपको मिल रहे हैं और इसमें 3 symptoms में TTP में आपके पास 5 symptoms हैं, all these, and HUS में you have these 3. Now one by one we will discuss what is it. The thrombotic thrombocytopenic purpura. The thrombotic cytopenic purpura, here you can see the अच्छा ये मैं आपको बता दूं, this term thrombotic microangiopathies, it includes TTP and HUS. TTP is a pentad, जो मैंने अभी आपको पहले बताया, and this hemolytic uremic syndrome is a triad, right? Now the thrombotic thrombocytopenic purpura. Thrombotic cytopenic purpura, this is associated with the deficiency of an enzyme in a plasma. This is known as the Adams 30. Adams 30, this one, right? Normally क्या होता है? It is present and it engulfs or phagocytoses the larger molecules of von Willebrand factor, and now the von Willebrand factor is not available for the platelets and there is no addition. So the count will remain normal and there is a continuation in the blood flow, a normal regular blood flow. Suppose if this enzyme is not present, there is a deficiency, maybe an inherited one or acquired one. Now deficiency of this enzyme, the Adams 13, this will lead to the addition of the platelet to the larger molecule of von Willebrand factor. Now this von Willebrand factor से ये attach होंगे, more and more platelet get attached to the von Willebrand factor, and there is that leads to the turbulence in the so in the absence of this, these multimers जो जहाँ पे normally जो है इसको ये engulf करते हैं, normal function of this Adams 13 क्या है कि ये जो von Willebrand factors के larger molecules हैं इनको phagocytose करते हैं, engulf करते हैं. If this will not present, it will remain there, the platelet get attached to this and leads to the turbulence in the blood. Again, this is a similar picture showing you the effect of or the deficiency of this enzyme. So here you can see the circulating ultra large von Willebrand factors, multiples हैं यहाँ पे, and there is no enzyme, this enzyme. ठीक है? So if this enzyme is not present, the more and more platelet get attached to this and leads to the this event, right? अगर ये present है तो it will cut down this larger von Willebrand factor multimers and lead to normal circulation. If it is not present, it leads to this thrombotic event. यहाँ पे देखें आपकी narrowing of the vessel हो रही है due to the attachment of the platelet to this von Willebrand factor. It leads to the platelet, more and more platelet adhesion. It leads to the narrowing of the vessels. Narrowing of the vessels lead to this, all this. ठीक है, जब blood flow सही नहीं होगा, that leads to tissue ischemia and that leads to the cystocytes. ठीक है, जब इसमें से blood vessels narrow हो जाएंगी vessels, when the RBCs pass through this narrow vessels, there is alteration in the shape of the RBCs. and that may lead to the fragmented RBCs or the deranged or D-shaped RBCs, and this is known as the schistocytes. So here you can see the fragmented RBCs. These are known as the schistocytes. So it's very, very important in the thrombotic thrombocytopenic purpura or in the microangiopathies. It will lead to the microthrombi and it may further lead to complication. So this thrombotic thrombocytopenic purpura may be due to the deficiency, maybe autoantibodies antibodies inhibitor of this, unless one of the rare congenital form with no inhibitor. It may be due to the hemolytic uremic syndrome, and this may be due to associated with recognized complement activation condition in 2/3 of cases, congenital mutation in complement system recognized in 70% of the cases. It may be due to the sugar-like toxin that is produced by the E. coli that leads to the hemolytic uremic syndrome. This is the hemorrhagic strain of the E. coli that leads to the hemolysis. The hemolysis, excessive hemolysis leads to the kidney shutdown, and it leads to uremia and this hemolytic uremic syndrome. So stool samples of rectal stone positive for E. coli producing sugar-like toxins by culture. This E. coli will produce the sugar-like toxins. The sugar-like toxins kya hai? Basically, sugar is causing the bloody dysentery. Bloody stool cause karega, dysentery cause karega. So the E. coli, one of the strain of E. coli is known as the hemolytic uremic strain, and this hemorrhagic strain leads to the dysentery, and this excessive bleeding sometimes leads to the kidney shutdown, because उसमें से वो RBCs pass होंगे, kidney shutdown होगा, it leads to uremia, and it leads to hemolytic uremic syndrome. So the clinical features of hemolytic uremic syndrome: thrombocytopenia, this microangiopathic hemolytic anemia, this renal involvement, thrombocytopenia, microangiopathic hemolytic anemia, mild renal involvement, fever, and the CNS involvement. So it occurs in children, और ये बड़ों में होता है. Mechanism जो है HUS का may be due to diarrhea, maybe alternate complement disorders we have already discussed, and it is due to the enzyme deficiency, TTP. So here you can see maybe the platelet consumption होगी, thrombocytopenia हो सकता है, maybe schistocytes हो सकते हैं, this LDH, serum bilirubin count increase होगा. There is no जो आपके clotting factors उनके involvement नहीं है, तो coagulation profile will remain normal, and PTA, PTT will be normal in this condition. Then here you can see use the schistocytes fragmented RBCs, which is very important in the microangiopathies. Now, DIC is an acute, subacute, or chronic hemorrhagic disorder that is characterized by the excessive activation of coagulation and the formation of thrombi in the microvasculature of the body. There you can see the normal mechanism, the intrinsic and extrinsic pathway, coagulation pathway. So ultimately, जो है, that leads to all these factors leads to the activation of this factor 10A को करते हैं, and that leads to the prothrombin formation. The prothrombin will be converted into the thrombin, and that fibrinogen that convert the fibrinogen into the fibrin, and that leads to the clot formation. So this is the intrinsic pathway and extrinsic pathway. यहाँ पे आपकी fibrin form हो जाएगा. Now the fibrin form जब होगा, that fibrinogen is converted into the fibrin, and that may lead to fibrin degradation product due to the fibrinolysis. Plasminogen will get converted into the plasmin, and that causing the breakdown of the fibrin, and the fibrin degradation products will be formed. This is the normal mechanism we have already, and you have already done in your physiology. Now, DIC could result from pathological activation of the extrinsic or the intrinsic pathway of coagulation, or it may be due to the impairment of the clot inhibiting mechanism. ठीक है, यहाँ जो clot formation हो रही है, उसका inhibiting mechanism भी होता है, उसको inhibit भी किया जाता है, तो दोनों की impairment हो सकती है, या activation हो जाएगी extrinsic और intrinsic pathway की, or maybe there is impairment of the clot inhibiting mechanism. Two major mechanisms trigger DIC: release of the tissue factors or others, and widespread injury to the endothelial cells. Here you can see the endothelial cells and activity that leads to inflammation and activation of all these factors. Associated clinical features that may lead to DIC: sepsis or secondary trauma, cancer, obstetrical complications, vascular hemangioma, aortic aneurysm, reaction to toxins, immunological disorders. DIC and infectious diseases, severe sepsis is the most common clinical condition associated with the DIC, bacterial infection, the gram-negative sepsis, lipopolysaccharide responsible for causing the shock, gram-positive sepsis, exotoxins or may lead to the shock-like condition. DIC and severe trauma, especially seen after the brain trauma, release of fats and phospholipid cytokine activation, similar patterns to severe sepsis, systemic inflammatory response syndrome after trauma, 50 to 70% associated with the DIC. Certain tumors are responsible for causing the DIC. They produce certain procoagulants and the tissue factors, and that may lead to the DIC. So DIC this is an example. Acute promyelocytic leukemia may lead to the DIC. DIC and obstetrical disorders, abruptio placenta, amniotic fluid embolism, fetal death, and uteroseptic abortion. Again, all these may lead to the DIC. Eclamptic conditions, so this may lead to the DIC. What is the pathogenesis of the DIC? Increased thrombin generation, very, very important. That leads to the clot formation all over the body. Depression of physiological anticoagulant mechanism and delayed removal of fibrin due to impaired fibrinolysis. Maybe activation of the intrinsic and active pathway, extrinsic pathway, and the impairment of this fibrinolysis pathway. So thrombin generation कब होगी और कैसे होगी? Maybe due to the extrinsic pathway activation and tissue factor release and factor 7A. So fibrinolytic defect may be increased plasminogen activator inhibitors type 1. So this is the pathogenesis, the widespread activation of the coagulation. So in this case, where you can see the generalized endothelial damage that leads to the generalized platelet aggregation. Now, this generalized platelet aggregation leads to consumption of the platelet. That leads to decreased platelet count in the circulation. So after the release of certain tissue factors or due to damage to the endothelium, there is activation of certain clotting factors with extrinsic pathway activator and intrinsic pathway that leads to widespread extravasation of the coagulation. So it may lead to the microthrombi in the circulation that will ultimately decrease the clotting factors and the platelet count, which increase chances of the bleeding. So, and increase the fibrin degradation product in the circulation. So here you can see the damage to vascular endothelium leads to platelet adherence to injured cells, platelet activation, aggregates, and then the coagulation takes place. Tissue factors, this activate the tissue factors, and ultimately it will lead to the activation of these two factors and thrombin generation. Now fibrinogens will be converted into the fibrin that prevent further bleeding and initiate vascular repair, right? So then pathological conditions, this coagulation pathway overcome inhibitory mechanism, increase consumption of coagulation factors and platelets, thrombus formation at the site and microcirculation leads to hemorrhagic syndrome. This is known as the DIC. Consequences, there is widespread deposition of fibrin within the microcirculation that leads to ischemia of most severely affected. The consumption of platelet and clotting factors and activation of plasminogen leads to hemorrhagic dialysis. This is an imbalance between these two. Okay, widespread clotting forms clot, breakdown clots, and depletion of the clotting factors leads to depleting. This all widespread clotting leads to organ ischemia, and there is widespread clotting. There is a narrowing of the vessel, tissue ischemia, and organ ischemia. Or consumption of these clotting factors leads to decreased clotting factors, bleeding. So there may lead to the organ ischemia as well as they may lead to bleeding in the DIC. Increased clotting, consumption of the platelet. Increased consumption of the clotting factors leads to thrombus formation at the site of injury in microcirculation. Hemorrhagic syndromes for the DIC. Now this is the overall picture. You can see DIC, uncontrolled thrombin generation, fibrin deposition in the microcirculation or the consumption of platelet and coagulation. Now, due to consumption of platelet and coagulation factors, diffuse bleeding may occur. Fibrin deposit in microcirculation leads to the ischemic tissue damage, RBCs damage हो सकते हैं, hemolysis हो सकता है. It may lead to the secondary fibrinolysis. ठीक है, तो यहाँ पे multiple ischemia होगा that leads to failure of the multiple organs, and if there is the secondary fibrinolysis that leads to the vessel patency and the increased fibrin degradation product, which is very, very D-dimer, very important in the DIC. and that may lead to diffuse bleeding. Again, the similar things, the massive tissue destruction, product of conception, such as endothelial injury. These all are the causes of the DIC. So that releases the release of the tissue factors that leads to widespread microvascular thrombi. If there is an endothelial injury, there is a platelet aggregation that leads to thrombus formation. When there is a thrombus formation, it leads to activation of plasmin that leads to fibrinolysis, and the fibrin split products will be formed. So inhibition of thrombin, platelet aggregation and fibrin polymerization. ठीक है, यहाँ पे आपके fibrin जो D-dimer split products are formed. Now, activation of the plasmin also leads to proteolysis of the clotting factors, and that leads to the bleeding. Okay, and then the thrombus formation, consumption of the clotting factors leads to bleeding. Thrombus formation leads to vascular occlusion, may leads to microangiopathic hemolytic anemia, ischemia, tissue damage, and ultimately, due to the consumption of all the platelets and clotting factors, leads to bleeding. The thrombi most often found in the brain, heart, lung, kidney, adrenal, and it may affect any organ. In severe cases, bilateral renal cortical necrosis can be seen. In meningococemia, fibrin thrombi with any microcirculation of adrenal cortex cause massive adrenal hemorrhages in Waterhouse-Friderichsen syndrome. An unusual form of DIC can association with giant hemangiomas in which the thrombi form within the neoplasm because of distasis and recurrent trauma to fragile blood vessels. These are the clinical features: microangiopathic hemolytic anemia, dyspnea, cyanosis, respiratory failure, conversion and coma, oliguria, and acute renal failure, sudden progressive circulatory failure, and shock. In general, acute DIC associated obstructive complication or major trauma is dominated by bleeding diathesis. Chronic DIC, such as a cancer patient, tends to present with thrombotic complication. Clinical approach to bleeding disorder: screening, laboratory evaluation, platelet counts, coagulation profile, prothrombin time, activated partial thromboplastin, and bleeding time. Microangiopathic hemolytic anemia will lead to anemia, thrombocytopenia, fragmented RBC histiocytes in the pair of blood, a feature common to several conditions. DIC, thrombotic thrombocytopenic purpura, and hemolytic uremic syndrome. This is a paper showing you the schistocytes. These are the fragmented RBCs. So lab results: prolonged PTA-PTT, reduced fibrinogen level, increased D-dimers, thrombocytopenia, microangiopathic changes in the blood film. This is the overall pictures or lab values showing you the DIC. So this is the difference between the TTP versus the DIC. So in this TTP, there is a decrease in the platelet. DIC may be decreased only, blood may show the schistocyte, blood may show the, because both are the microangiopathic hemolytic, and the PTA-PT normal increase in the DIC, LDH increase in both cases. Fibrinogen will be normal in TTP, will decrease in the DIC. D-dimer will be normal in the TTP and increase in the DIC. Thank you so much. This is all about the TTP, HUS, and DIC.